So, like you said, my name is Behr. I'm a registered nurse, full disclosure, I'm not a stroke boarder. I graduated from WB School of Nursing in 1999, and I've worked in the since, both as an outpatient nurse and inpatient. My current position is as a nurse educator with Plaza Puffman. Plaza Puffman is a local outpatient HIV multidisciplinary care team that sees patients, serves really basically the top half of West Virginia. Made a belt across West Virginia's supple midsection at about the Braxton County line. We serve all the patients up above in both panhandles. We also see patients from southwestern Pennsylvania and from western New York. So today I'm just going to talk a little bit about HIV and social work and how social workers can tremendous influence in this population. We'll talk just briefly about the virus itself. We'll get right into the care and treatment, and then I'll talk a little bit about the local resources. It's not the kind of thing I would expect anybody to necessarily commit to memory in terms of what the resources, but just knowing that there's local resources, so that way, if and when the time comes to come in contact with somebody that either needs referred or is at risk for HIV and needs referred to testing, you'll remember hopefully all the resources. So just real super brief, HIV is the virus that causes AIDS. AIDS is a medical diagnosis. So some people kind of use the terms interchangeably, and they are different. So HIV is the actual virus that binds to a cell in the immune system that weakens it. Over time, if your immune system becomes so weakened, your CD4 count drops below a certain level and you become vulnerable to certain opportunistic infections, that is a diagnosis. AIDS. AIDS stands for acquired immune deficiency syndrome. And so it's important to understand that in this day and age with care and treatment, people can absolutely rebuild their immune system back up. However, medically speaking, we do continue to carry that diagnosis of AIDS in the person's medical chart because it just sort of shows the medical providers that their immune system is a big hit. HIV is transmitted through blood and sexual body fluids. It's important for me to point out, even in this day and age, it's not in saliva, it's not in urine, it's not in sweat. If those fluids are bloody, blood that is infectious. It can be passed from infected mother to unborn child, either during pregnancy, during delivery, or through breast milk should the mother nurse. We've really made such advances in treating to prevent what they call perinatal transmission. So in the United States, we have the mother-to-child transmission rate to right below 2 to 1%. It's very, very minimal. But that takes resources, right? The woman has to know she's pregnant. The woman has to know she's positive. She has to be in care, taking medications. And so again, that's a big step, right? Just to cover the pregnancy. If she's treated all throughout the pregnancy, and then depending on what her lab values are at the time of delivery, if her viral load is low enough, it's safer to do a vaginal birth. If it's above a certain point, they feel like it's safer to do a C-section. However, if a woman has not received prenatal care, didn't receive testing, didn't receive treatment, that does put that newborn at risk. Once the baby's delivered, you can give the baby HIV medication to prevent what they call seroconversion if you were exposed becoming positive. And then obviously the mother cannot breastfeed, which again, in this country, we have lots of resources to like WIC and other supportive services to provide formula for the baby. But in developing countries, all these steps are much more difficult to achieve. So perinatal transmission is still very much a risk for children in developing countries. This is a statistic that or just a bit of information that I love to share with people all the time, because when I share with people that I work with HIV patients, I get a lot of, oh, that movie Philadelphia was so good. You know, people still associate it with being a death sentence, and it is not. People living with HIV in this day and age, if they're in care and they're on treatment, they're living a normal life expectancy. I like to joke that people now living with HIV have earned the right to die from smoking-related diseases and cancers and heart attacks and strokes, just like, oh, the rest of America. But it's true. But again, it requires being in care, taking your medications every day without fail, getting your labs checked, and it's managing a chronic illness at this point. The other thing that gets me really excited about HIV is the testing sophistication. So years ago, when a person wanted to get an HIV test, either a medical person told them they should be screened, or they did something that they considered risky and they needed to be tested, it took weeks. They had to go to like doctor's office or the local health department have a tube of blood drawn, sent away to a lab where it's screened. It would take a couple of weeks to get the results back. And oftentimes those people, they might have been brave enough to get that initial test. They weren't brave enough to come back to get the results. And so now they've gotten the sophistication of the test that we can do a rapid test from a simple drop of blood, like someone's checking a blood sugar, and get confirmed HIV test results in 20 minutes. So that's really shortened down that window, being able to give that person that information right there, and then work to refer them into whatever kind of resource they might need. 2 weeks to 20 minutes, just woo, gets me excited. A little bit about some current statistics and info from the CDC. There's approximately 1.1 million people living with HIV, the virus that causes AIDS. 1 in 7 of those 1.1 million don't know they're infected. And that's where predominantly the number of new infections come from. Every now and then in the news, there'll be a kind of over-exaggerated case of somebody who was willingly or knowingly exposing people to HIV, but the vast majority, even people who are positive, do not want to spread this to anyone. It's people that don't know they're infected that are engaging in risky behaviors, and they don't know that they're infected, so they're not taking any precautions to prevent the spread. There are approximately 38,500 new cases of HIV every year, and again, it's from people who don't know that they're positive, but that are either engaging in unprotected sex or sharing needles. We'll talk about both of those. Again, normal life expectancy if you're in care and on treatment now, but that comes at great cost, obviously. Approximate cost, and this is kind of a lowball average cost for HIV medications, are almost $1,700 a month. There are insurances and Medicaid programs, and HIV medications are covered by ACA formularies. But again, a person has to have the resources to know how to engage. Oftentimes the patients that I see, they've never really engaged in medical care until they found out they're HIV positive. And there's all kinds of hoops to jump through. You guys know, you know about the paperwork and understanding medical literacy and all that kind of stuff can be really overwhelming, particularly depending on what else is going on with that patient. For a lot of our patients, the fact that they're HIV positive is so far down on the list, it barely even, hits the radar. And the cost of the medications, that doesn't cover the cost of doctor's visits, it doesn't cost lab visits, transportation. That's a huge issue that we face in West Virginia, is just getting people to their appointments. If they're outside of Mon County, trying to get them here, and those are conversations. If you've been to conferences or workshops with people from bigger cities and you tell them transportation is an issue, they look at you like, what do you mean? Well, they've got buses and metros and all kinds of systems in place, and we don't have that. So that becomes an issue. Another thing that I think people don't realize is in existence that we're really excited about is this preventative medication to prevent becoming positive should you be exposed. It's called PrEP. It stands for PreExposure Prophylaxis. I compare it to sunblock. You apply sunblock to your body to prevent a sunburn in case you should come in contact with the sun's rays, right? PrEP is a medication. It's a HIV medication we've used successfully in patients for years. You take it at the same time every day. And should you come in contact with the virus, having that PrEP in your bloodstream would prevent you from becoming positive. So that's been huge. But again, it takes resources and education to be able to get it and take it every day. Question?
Well, how does that work for the PrEP? Because is that for folks that are, did they just know that they're willingly going to engage in this behavior?
Well, it's generally for people.
Providers?
Typically, we see it mostly in people who feel they're at risk because of sexual exposure. I haven't seen very many patients even who are actively injecting drugs looking for PrEP. I've seen the partners of people who know their partners are using drugs put themselves on PrEP as a preventative measure. Like, I know my partner may relapse, and that puts me at risk for HIV, so I'm going to take PrEP myself.
Because they're not willing to use,
because they're not willing. Exactly. Yeah. And then other times it's people who, are just worried. Either they are practicing safer sex, but it's an additional protective layer, so to speak, because condoms can fail. Or it's people that they know that they're not the best at using condoms, and so this is going to prevent them from contracting HIV. And I should have said this at the beginning. Please, anytime you have a question, throw it out there, because I think that starts a really great conversation.
So what's the cost of that medication?
It runs around $1,000. It's actually a combination of 2 medications that we've used for a really long time successfully in our HIV positive patients. And they did a lot of long-term studies, and they showed that if a person took it every day, they have that blood level that should they come in contact with the virus, they wouldn't contract it. Insurances are starting to cover it. There are certain state agencies that are starting to provide it to people because they see it's, in terms of long-term cost reduction, it's much easier and cheaper to provide PrEP for patients than it is to treat people who get infected. San Francisco in particular was a real epicenter for the epidemic early on, and they've really taken steps to make sure that anybody who needs PrEP can get it. The manufacturer of the medicine, it's called Truvada. They have programs that you can apply. If you don't have any other way to get it, you can get it through the drug company. So let's see. All right. I had a handout. Did I get everybody a copy of the handout? Oh, I didn't. So this is just a handout. I get excited about epidemiological data because if you've ever tracked any kind of epi data, you know it's always old, right? They're looking at data from the previous year and tabulating it this year. But I got really excited because the date on this handout was actually December 2018, and I never get statistics that fresh. So this is just a little bit about that picture. I said we've got a little over 38,500 new diagnoses of HIV in the United States, and this is a breakdown. So keep in mind, this is data they collected in 2017. They tabulated it in 2018. So Epidata, as recent as it is, it's always a little bit, usually a year older. So this is a little bit of the breakdown. You've got 66% of, excuse me, the people that are, I'm sorry, I have something on the screen. I don't know what happened.
Oh, just hit that little hyphen on the top left.
Okay. Oh, okay. So men who have sex with men are the most affected subpopulation of HIV. And just as a little side note, the reason that we specify men who have sex with men and not just refer to them as gay men is because we have a lot of patients out there, a lot of individuals who have in the past or in the future will have contact with other men, but they don't identify as gay. And so we use that MSM term as kind of an umbrella term, especially in more rural places. Identifying as gay can get you fired, can get you kicked out of your family, can get you beat up or worse. And so we try to recognize that not everybody is willing to identify as gay when you're talking about risk behavior. Also, people of color are disproportionately infected with HIV. And so a lot of times we're faced with struggles of how do we reach people in the margins that are struggling, right? People either they don't feel represented or they feel like they're going to be judged. Young people also are making up more than half of all new infections, 13 to 34. You're talking about high school and college and just out, right? Years ago, the CDC came out with guidelines that said that everybody ages 14 to 64 should have one baseline test. And that was their attempt to identify that large number of people that are positive that don't know they're infected. And the idea is they had a whole campaign. It was, are you positive? You're negative, right? Because a lot of times people are just operating under the assumption that, well, I'm fine. I don't look sick. I feel fine. I'm probably not positive. But still, a lot of folks don't understand maybe what has put them at risk. So the idea was to get your baseline, and then you can move forward. You can either understand and take the steps to stay negative, or if you find out that you're positive, you can get into care. And then the other thing I wanted to point out is this treatment cascade. It's on the back page. It's on the page at the top where it says 6 and 7, they have the virus. So we talk about treatment cascades. That's kind of like the hot topic in HIV medicine. It's the idea of your patients, how many of them are in regular care, and of the patients that are in regular care, how many of them have what we call an undetectable viral load. That means they're taking their medicine every day and their virus is so minimized that our regular labs can't detect it. And so of every 100 HIV positive people living in the United States in 2015, only 63% received some HIV care. So that's a really significant drop off. A little under 50% were retained in care. So obviously there's a big difference between getting referred and making that first doctor's appointment or getting in and seeing the provider once or twice and then falling out of care, either transportation resources, substance abuse, relapse. There's a whole host of reasons why people fall out of care. And then 51% were virally suppressed. So that's something that at the WV Positive Health Clinic, our treatment cascade is much higher, and it's something we are pretty proud of. But again, you're looking at resources and all sorts of reasons why people fall out of care or are unable to take their medicine on a regular basis. We talked a little bit about MSM and the sexual exchange that leads to HIV infection, but injection drug use is the other big one, particularly if you guys are familiar with the stuff that's happening in this area around the opioid epidemic, that's something we're really concerned about. So people who inject drugs with shared needles, as well as the sexual partners of people who are injecting drugs, are increased risk for HIV infection. 6% of new infections are a result of injection drug use. And again, remember, this is slightly older data, and I do worry that as we start looking in a few years, as we're looking back at now, what's that data? Where's that data going? Early screening and testing are key for minimizing the spread of HIV. But again, getting folks who are in the throes of an active addiction into regular outpatient care, syringe exchange programs, it can be really difficult because of their active addiction. You get them on one day and they're having a good day and they're willing to try different things to stay healthy, and then something happens and they relapse, or they go back with an X that helps them use, or there's all these different challenges. Harm reduction techniques such as cleaning needles, helping show a patient how to clean their needle and their works, and even just understanding how a person injects the drug. How did they prepare the drug? How do they mix it? What are the tools that they use? That way you know where you can kind of intervene a little bit and say, I see you're doing it this way. Have you thought about trying it this way? Because it would make it safer or cleaner or whatever. There's also syringe exchange programs. There's a very successful one here in Morgantown being run out of HealthRight. It's called the Lake Program, Living in Good Health Together. They provide a whole host of services: HIV testing, Hep C testing, needle, syringe exchange, along with the other supplies that a person needs to inject, but also referral to resources and treatment and support groups and a whole host of things. It takes a lot of community buy-in, however, from local law enforcement, from local politicians. And I understand that people go, well, that's just giving people permission to use, but we know that it does not cause a decrease in drug use. It can decrease infections like HIV and Hep C. It can save lives just in terms of getting Narcan out onto the streets where they might be used. And then people that are involved, this is the big number that makes me happy, is the people that are involved with syringe exchange programs are 5 times more likely to enter treatment. So the idea is that having Narcan out there keeps them alive, keeps them healthy, so when they can enter treatment, they're ready to.
The treatment perhaps including like a methadone clinic? Or
Sure, methadone, medication-assisted treatment, inpatient rehabilitation, whatever they're, yeah. But just having built a relationship with a program where they know they're not being judged means that when they're putting themselves out there and super vulnerable, they've already established that relationship. It's really important. This is just something I like to talk about a little bit because Epi data makes me happy. A couple of years ago, you may have seen in the news, or if you listen to NPR, there's a really great podcast about this. In the tail end of 2015, there was a pretty significant HIV outbreak in a rural part of southern Indiana called Scott County. Ultimately, they identified 235 cases of HIV that all blossomed, as you can see. It's a weird little thing, but these red blobs represent HIV positive people, and a circle that size is 56. So all these little clusters were either people that had shared needles, or again, were the sexual partners. So you have injection drug use, both sex and drug use together as a risk factor, and then sexual risk. It was really significant. It was at a time when there was not syringe exchange in that area at the time, and you can see it spreads like wildfire. We worry that West Virginia is certainly at great risk for something similar. We have a local, his title is a disease intervention specialist. So there's people sort of scattered all across the state that are state health department workers that track down various transmittable diseases, and HIV is one of them. And so we're in constant communication with him, just kind of waiting a little bit for what's the tip of our iceberg. We worry about these kind of places in rural parts of West Virginia. The CDC looked at some of the factors that influenced this outbreak and then projected it onto Appalachia. Half of West Virginia is considered high risk for something similar like this with either HIV or hepatitis C. And again, if this is something that you're interested in, NPR had a wonderful podcast on their series called Embedded, where a reporter actually went to this house where people bought and shared drugs and talked to a cluster of people. They felt like it was kind of the epicenter of this outbreak. And it was really, really interesting to feel like that kind of stuff. So, any questions about this? It's alarming, I think, when you see it visually like this. Let's see. All right. So care and treatment. I said earlier that the CDC recommends everyone be screened for HIV. That's going to help identify that 1 in 7 that aren't aware they're positive. These are primarily the settings where we encounter newly diagnosed patients. When I'm meeting a patient who was diagnosed inpatient, they are more than likely very sick. You can live with HIV for up to 10 years before you start to really, really get sick. And so oftentimes when we're meeting patient inpatient, they've got terrible pneumonias, terrible abdominal infections, brain infections, very, very low CD4 count, really, really weakened immune system. We are able to, with the treatment we have now, bring them back. Sometimes it seems like from the dead, but it's really hard because we're trying to do patient, education with them, and you when you're trying to do partner identification, we'll speak to them and say, what are your risk factors? And if we'd had a better system in place to identify that person years before, who knows how much better their health would have been, and also how many fewer people they would have exposed. The local health departments, every health department in West Virginia offers HIV testing, and they have STD clinics. The phrase that I like to use, I stole it again from a different podcast, is if there's a sore, there's a door, which just means if you have an existing sexually transmitted disease that you're unaware of, that's not been treated, you come in contact with HIV, it's even more likely that you're going to become infected because of the infectious nature that's already happening. You've got sores and all sorts of things happening. So if you're a social worker who's working with people who are in any kind of STD clinic or complaining and things like that, like just keeping that in the back of your head and knowing, hey, you may want to consider referring, if you're dealing with part of a medical team, saying, hey, maybe we should get this person HIV tested, or encouraging that patient to request testing. Drug treatment facilities and syringe service programs also are places, particularly in the areas, more and more of them are popping up, where they're helping people get screened and tested. Our emergency department is participating in, they call this focus project. So it's another way to identify people that are possibly at risk who have never been screened before. And we've received patients from our emergency department who they were offered screening. They said yes. I mean, I have one patient who went in for a knee injury, and she found out later she was HIV positive. Like, it just completely happened that she said, sure, I'll do that, not expecting to be positive. And so what that meant was we were able to get her into care far earlier than she would have been otherwise.
So how often is that offered to someone who would go to the emergency room being sick or having an injury? Because they can be there. And if that's not offered, then there's no way to know that they're HIV positive.
That's a really great question. And what it takes, and some of my colleagues, it's their mission and their whole function is to educate healthcare providers. So getting doctors and NPs and PAs and all those providers that are working in emergency departments to consider HIV, right? But it also means if somebody comes in with flu-like symptoms, it means talking to them about sex. Because one of the first things that happens when a person becomes infected and they have what's called the acute retroviral syndrome, the strong majority of patients will have a flu-like illness. Swollen lymph nodes, sore throat, fever, body aches, chills, sounds like every flu that everybody else has ever had, right? And I've gone to urgent cares and stuff before with those symptoms and have never once been asked, tell me about your sexual health history or your injection drug use. So providers are not keeping it on their differential when they're thinking about stuff like that. And so my colleagues that work with the local AIDS Education and Training Center, they're educating healthcare providers to keep it in their minds when they're looking at a patient. But it also just means getting that education out there, like the young woman that had the knee injury. I think they offered it to her. She said sure, and I don't think anybody was prepared for the results.
Do you think was that a sexual contact with a partner? Because
I don't know her details, actually. I don't know her
guess,
details.
if she thought she was at risk,
Sure, yeah. No, I don't know the details on that. HIV Testing Events, World AIDS Day is December 1st. And then HIV Testing Day is June 19th. So oftentimes programs will put together just large number testing events. We had one on World AIDS Day in conjunction with Health Right and the university. OBGYN care, obviously, and primary care providers, you can always present. Student health's another location. There is a home test that a person can purchase and use, but I generally, for the most part, strongly discourage a person from using that. It can be mishandled. The results can be misinterpreted. God forbid it should come back positive. You're sitting there in your place all by yourself, like, you know, not having a person to ask questions to. When they give you a telephone number, you can call with questions, but it's not the same as having a warm-bodied person across from you giving you these results and then telling you how you can get plugged into care. That's tough. I feel like I need to apologize for this slide because PowerPoint helped me with the layout. And I don't know if you've ever made a PowerPoint slide and you click on the side and it says design ideas. Well, this was totally PowerPoint slide idea, design idea. I think it looks kind of extra, but it's made it the bullet points pretty snazzy. So in terms of HIV care and treatment, you've got infectious disease physicians. These days are primarily the providers that are seeing patients. When I first got into HIV care, we were seeing patients once a month to once every 3 months. It got really, like, it was a really big deal when they started pushing patients to once every 4 months for care. Now our stable patients are physically being seen in the office once a year, as long as they get their labs drawn twice. That's been a huge shift in getting folks to think they're no longer a person that's sick. They're a healthy person just managing a chronic illness. Now, obviously, people that have other things going on, we do bring them in more frequently, but this chronic, we call it our chronic care model, has been just tremendous. I mean, again, and you're talking about limited resources, right? So a person that's traveling up from the Braxton County area that went from having to travel up once a month or once every 3 months to once a year, that's been huge as long as they're getting their labs drawn at a local facility. We follow regular lab work. The 2 labs that most of our patients are interested in that we follow to manage how they're taking their meds and how their immune system is responding is called the CD4 that I talked about. That's the part of the immune system that the HIV virus actually binds onto and ceases it from functioning. And then the viral load, that's the amount of virus in your blood. So typically what happens is as your CD4 count goes down, the viral load goes up. You start taking medications, viral load goes down, and your immune system can build itself back up. That's the prettiest ringtone. I love it. Again, access to medicine is huge, but there are side effects. The newer drugs are a little bit cleaner in terms of side effects. So we really encourage people when they're taking their treatment to take it every day as prescribed, not miss doses, because over time, skipped doses can lead to viral resistance. Then you're taking older classes of drugs that have a little bit more significant side effects. But we're watching for kidney function, liver function, cholesterol levels. Bone density is an issue that we're starting to see in some of our aging patients. The older medications leached calcium out of their bones, and now they're having spontaneous fractures and stuff like that. Because HIV positive patients are living a normal life expectancy, we're talking to them about things like smoking cessation. That's really primarily what I'm doing at the clinic as an educator, as I'm talking to people about the importance of quitting smoking, not hitting the drive-through for the Big Mac, trying to get a little bit of weight off, moving, getting a little physical activity to prevent heart attacks and strokes, and mental health support. We've got part of our team at the Positive Health Clinic is behavioral medicine. They can come in and see patients when they're in seeing us and make sure they're being managed for things like depression and anxiety. Yeah, unfortunately now patients see me coming and they're like, oh, there's the girl that's gonna tell me I gotta eat cells and quit smoking. But we didn't have those conversations with our patients 15 years ago, They weren't dying from smoking related issues and heart attacks. They were dying from HIV. And so the fact that we get to have those conversations now is thrilling. So this is a little bit about PrEP that I mentioned at the beginning of the presentation, the pre-exposure prophylaxis. Person has to be screened for HIV, obviously, before they start PrEP. It can reduce the risk. And we do actually have a coworker of mine, her name's Katie Behr, her information is there at the bottom. She is our local provider. Any prescribing provider can write a prescription for PrEP. Oftentimes it comes down to the provider's comfort level. They need to know how to manage it. Again, you only have to be seen a couple of times a year with some lab exams that follow your liver function and kidney function and stuff like that. But a lot of times providers, they hear HIV med and they kind of go, well, I don't know what I'm doing. So we do have a provider that's prescribing, and she's seeing quite a lot of PrEP patients now.
When it says the person must be screened, that's to assume that they already have it.
Correct. Because if you were to start somebody who's infected on PrEP, it's only a 2-drug regimen, they would very quickly develop resistance, which would then make it much harder for them to treat the virus. So a little bit about care resources. The Ryan White Care Act was established in 1990 through HRSA. It's the largest federally funded program that serves people living with HIV and AIDS. It's meant to be a payer of last resort. So you guys that are familiar with all the different sort of pay structures and Medicaid, Medicare, all these things, Ryan White exists for people who don't qualify for other payment means. Every couple of years, they change what they call the CARE Act just to keep us on our toes. It used to be titles. It's currently parts. So imagine it's this giant pie and there's different wedges or parts of the pie that serve different needs. The first section was initially back in the 90s established for major metropolitan areas because they were primarily the big places where large numbers of HIV positive patients were identified and were living and were dying. Additional money went out for primary care. Another pie wedge is for women and children. There's an additional pie wedge that provides healthcare education, the AETC that I mentioned. Those all fall under CARE Act services. So the clinic that I work at is part of that primary care part or wedge. There's an additional clinic down in Charleston. So between these two programs, the program in Morgantown and the program in Charleston, we're seeing the entire state of West Virginia. We get primarily the Part C, which is the primary care. Part D is the women and children. But again, our numbers in terms of women and children are very low because we've been so successful at treating and preventing perinatal transmission. In addition to our Morgantown clinic location, our Morgantown staff, we also have a traveling clinic that goes up to the Wheeling Northern Panhandle area once every 3 months. We joke that we're like taking the village on the road. There's a provider in downtown Wheeling who has graciously now for probably almost 15 years just opened up his doors. He doesn't schedule patients that day. He lets us come up and we see anywhere between 12 and 16 patients all in a day. And it's in an effort to address those patients that we were having fall out of care because they couldn't make the drive down to Morgantown. We also, our medical team provides a little bit of telephone oversight to a clinic that's over in the Eastern Panhandle. If you're familiar with that area, it's the Shenandoah Valley Medical Center. They have some infectious disease providers that are seeing our patients, and we don't physically travel there. They just have a phone consultation once a month where they can kind of pick the brains of the medical team and have questions if they have about treatment and resources if they have concerns. Another part of that CARE Act is all specifically geared towards medication. It's Part B, the big pie wedge. It's called the ADAP program, the AIDS Drug Assistance Program. ADAP exists in every state. However, it functions a little bit differently in every state. It's the funds for it are administered a little bit differently in every state. West Virginia's Part B program is administered by the AIDS Task Force of Upper Howard Valley. Sorry, that was a mouthful. They have a team of medical case managers who, again, are scattered across the state to reach out and work with patients who need support getting HIV medication. So these are typically people who don't qualify for Medicaid, don't qualify for Medicare, or have the resources to access the ACA. The ACA really changed the game for our ADAP program. It helped the ADAP program save a lot of dollars, and the medical case managers were all put through a lot of Affordable Care Act training in order to be able to refer patients to that program. There's contact information there for the ADAP program in West Virginia if you were to, and again, all these kind of resources are online. So you'd never have to think, oh, I got to remember that phone number. You just could type in West Virginia AIDS drug help, and all these kind of resources would definitely be there. We don't use it quite so much anymore, really, because of the ACA, but the manufacturers of all these drugs have pretty generous patient assistance programs where you can apply and enroll patients. But again, they will generally have to not qualify for any other program. We typically are able to get folks to kind of plug into a slot before it gets to that, to the copay assistance need. Now there's actually two differences. Let me be a little more specific. There's patient assistance programs to help get the drugs themselves. There's copay assistance, which is much different. If a person has their own insurance, either through an employer or through an ACA program, and they're not getting any other kind of subsidy support, and they have a significant copay, which they oftentimes will because these drugs are so costly, these drug manufacturers will have copay assistance help too. So we're always stressing to the patient that there's always a workaround. There's always a way to fix it. A lot of times it's financial concerns are the reason that people fall out of care. They go to the pharmacy to get their drug. They find out there's a $100 copay. They don't have it and they just walk away and they never reach back out again, not realizing all these resources exist. There's additional supportive services. There's a program called HOPWA, Housing Opportunities for People with AIDS, that's administered through the Housing and Urban Development that supports the housing needs of people living with HIV. They understand that if a person doesn't, housing is healthcare. That's a very common kind of phrase that they'll use. Case management support, rental services, help with emergency housing and shelter, some other supportive resources. And West Virginia has 3 locations. There's Caritas House right here in Charleston, in Morgantown, Covenant House in Charleston, and the Community Network St. Martin. So hopefully you've already noticed all these different places where social workers can kind of insert themselves and affect change. Inpatient, it's definitely helping patients link up with insurance coverage, making sure, you know, what's the saying that discharge planning starts at admission, right? So helping immediately, okay, this person's been identified as HIV positive. You can't wait till the day of discharge to figure out how this person's going to go home with their drugs. And then being familiar with the outpatient care, so you know how to make those referrals. In an outpatient setting, definitely retention in care. It's great that you came to that first visit, but if you don't keep coming, your health is going to decline. And then identifying people that are struggling with other needs and linking them to those additional resources so that they can stay on top of their health. Community settings, definitely testing resources and outreaching opportunities. And then just being able to engage in an open dialogue with the client that you're meeting with about their risk factors and their behaviors and how they can maybe reduce their risk. It definitely helps to just become familiar with what's in your area so that you know who to talk to, who to ask for, and who to send a patient to should you encounter. Because I mean, at some point, you're going to encounter a client that is either positive and they know it and they're just found out and they're struggling, or they're positive and they don't know it. You can help them get identified and get into care, or that they're at risk. So it's just helpful to know your resources in your area. This shameless plug, this is the program that I work for. It's a whole team. We refer to ourselves lovingly as the village. You know, it takes the village to do whatever. Well, we're the village. It's a whole team of folks that are dedicated to providing care and treatment for people living with HIV. I don't know if this is going to work. I embedded no, it's not going to work. Well, there's my dog. That's my final slide. My sister does some addictions lectures on campus, and she has a small farm, so she always gets to post cool pictures of her pigs and chickens and goats. Well, I don't have pigs and chickens and goats. Thank you so much for coming and sharing an hour with me today. This is such a subject that I feel really passionately about, so I love meeting new people and getting to get the information out there. Does anybody have any questions? I feel like we did just about right. Yeah.
Thank you. It's
Sure.
really great, and you're really like engaging, like just even your intonation, like kept us focused, and thank you for that. Just want to ask, and I feel a little ignorant asking this, but
Sure.
in terms of delineating HIV from AIDS,
Yeah.
I understand that, but all the statistics are on the virus.
Yeah.
So I'm curious to know, like, how many cases of AIDS are there? I mean, are we seeing like tons less because it just doesn't get there? Do we have any stats on like 1 in 7 have AIDS each year?
Oh, you know, I didn't get. You can get that kind of data from the CDC. I didn't get too fine a point on that. The kind of trends that we're seeing are there are fewer people. There are fewer people dying from AIDS-related illnesses, like things like pneumonia and certain brain infections. And the number of people that are going from HIV positive to AIDS has declined, but you can get that data on the CDC.gov websites, but I didn't get quite that specific.
But it has lessened with all the other positive
Yeah.
trends for reducing virus and stuff.
Mm-hmm. Yeah.
That makes sense. But just,
Yeah. Mm-hmm. Sure. Any other questions?
I have a question. So can you say a little more about the ACA and how that impacted medications? Like are there new like regulations in the ACA about medication coverage, or?
Well, early on the discussion about the ACA was that they were going to be required to cover all approved HIV treatment. Obviously it was left up to them what kind of tiers they put them in. Our case managers worked really hard. They got, like I said, a lot of training to find out and tease out which plans were better for our population and which paid less. as the ACA has kind of evolved, we've gotten less and less choice. And again, that's going to vary from state to state too, right? States where there's a lot more in the marketplace available, there's a little bit more competition. That's happening less here in West Virginia as things have kind of shifted a little bit. I don't know if that answered your question, but
So
there
I guess
is,
I was
they
just
can
wondering,
get,
like, are there federal mandates in the ACA about specific to HIV, or is it just that people have to be covered by insurance and then the insurance companies?
I think the only thing that I know is that they said they had to cover all HIV because some insurances wanted to kind of pick and choose and tell the providers which regimens they could use and which regimens they couldn't, which doesn't go over very, very well for people who are long-term survivors who are starting to deal with resistance. They need to have the whole breadth of all the HIV meds available to them because the doctors kind of put together these cocktails based on their resistance.
Right.
So that was the only thing that I know that they said, okay, you can't force people to pick and choose, but then they can have like really high copays where it gets, it's great if you've got insurance, but if you can't afford to pick up your medicine, it's not. Yeah.
Question.
Sure.
Talking about insurance, and a lot of my people are on
Medicaid?
Medicaid.
Yes.
Now, does Medicaid cover?
Yes.
They
don't have any issues.
Okay.
Medicaid patients are not restricted. Again, it's the same thing. They have to cover. And every time a new drug is approved, they go through the process of getting it added to the Medicaid formulary.
My population I work with, most of them are not really engaging in a lot of risky behavior.
Mm-hmm.
They're already engaged in that risky behavior.
Right. Right. But as my population ages, they're becoming your population.
Well,
my oldest patient is 92.
I've had some people that I had strong suspicions that they was HIV positive. And, but you're right.
Yeah.
They kind of people that normally, they're kind of solitary. And a lot of them have basically been fiends that turned their backs on just living life. I've seen that. And, they're just, that's the kind of population I see.
Mm-hmm.
That have moved into my building. And, they're not engaging in the risky behavior anymore, but they have engaged in risky behavior. And because of that, their families they don't have a lot of family connection or friend connection. Lots of their friends are gone, their family is gone.
For sure, no, we definitely, that's another hot topic in HIV care is the graying of HIV. As these patients are living a normal life expectancy, a lot of them in the early 90s, they were told they were going to die. They have no retirement plans. They have no long-term care planning. They were told they were going to die, so they sort of sat around and waited for it, and here they are. They've survived, and now what?
Well, it's kind of a misconception that the elderly is not sexually active.
Oh, no, that's for sure.
I remember 15 years ago when I started working with the population, and we was going to extermination bugs and stuff, and we'd have to walk on the door, go in, say, I'm here with the exterminator, and I was like, whoa, a big clothes on. I don't want to see this.
Something about the necktie on the door.
And then from then on, I realized, I yelled very loud.
Yeah.
I'm coming in.
Yeah.
They're probably more active and they're reluctant to use any protection because, well, I'm old. I can't get pregnant.
That's exactly right. Yeah, they came from a generation where you didn't talk about condoms and how to use them properly. The assumption was that it was for birth control only, so if I went through menopause, woohoo! No, for sure. There's southern states where there's a high population of folks that retire there. There's programs that are really outreaching to senior populations to get the message out there. You can still get STDs, you can still get HIV, and yeah.
Ever since VA started handing out Viagra like it's candy to everybody, it's made everybody's life far more interesting.
Sure. Well, if you need to supply condoms down at your office, you let me know.
They don't want
They don't want
them.
Anybody else have any questions or comments? So thank you so much for coming out on this blustery Monday. I was really grateful they didn't cancel school. I was going to have to scramble to figure out what to do with my two kids at home. Thank you so much. Yeah,
Thank
thank
you
you.
for
Thank you
coming.
very much for reaching out
Yeah.
and setting this up.